simulates this, and this is called as the biphasic curve, which is classical in mainstem bronchus obstruction. And if we had done the PFT properly, we would have found that. So again, a lesson is always find all the missing pieces of your jigsaw. So in conclusion, no single approach can be regarded as perfect. And of course, there's always more than one way to skin a cat, diagnostically speaking. 74-year-old asthmatic lady with a moderate large exudative pleural effusion, breathless or mild exertion, brought from the US for evaluation. I don't know, I thought it was the other way around, but this lady comes from US for evaluation and thought to have a primary pleural process by the cardiologist there. And there are unspoken concerns of the relatives because there could be a neoplastic pleural effusion, possibly because of its exudative nature and the right slightly enlarged right parietal lymph node and a normal echocardiogram. So we look at it again, and then we thought we saw an inconsistency there. And that inconsistency was that this lady was too breathless even for that pleural effusion. She did not have PTE. She did not have any other cause. Now she was on a heavy dose of diuretics, and diuretics, as you know, can sometimes turn a transudative effusion into what is called as a pseudo-exudate. This lady had a pseudo-exudate. So we went back to the cardiologist. We did a BNP first, and then we went back to the cardiologist, and the cardiologist eventually he did a CAG, and she was found to have a heart disease afterward. This is very common because these are coordinate paths to diagnosis. Because when I diagnose a cardiac condition, it's only by eliminating the pulmonology conditions. I'm not a cardiologist. When the cardiology diagnoses a pulmonary condition, he does by eliminating the cardiac conditions that he is an expert of. So the pulmonologist says echo is perfectly normal, no issue here. Cardiologist says echo is perfectly normal, no cardiac issue, COPD. Pulmonologist says, how can it be COPD? Non-smoker, no risks. There's unlikely other AV issue, no history of asthma, no atopy, no current breeze, no hysterectomy, aspiration, no expectoration, unlikely lung problem, chest X-ray normal, no pneumothorax, no large effusion. Could it be PT? Do a CTPA, CTPA also normal. Now he's back to square one. Let's reconsider the facts. Could it not be CA, coronary artery disease only? And then he goes and tells the cardiologist. Again, cardiologist is difficult to please. Fold your hands, he says, could you please do an angio? Does an angio, and you have a CAG diagnosis there. Is having inspiration of twice. One is inspiration of that has been and of course, that Chinese doesn't because talking about Chinese very constantly saying the topic that very knowledge in 90 plus 2 years. In 1987 years, 2010, 3.5, 2008, 70 days. How are you going to